So next is systemic response to surgery. So first question, how does body respond to surgical insult? Whenever we have a trauma, we have an infection, our body has a stress, then our sympathetic nervous system is activated due to the pain or hypovolemia, and it secretes certain hormones like adrenaline, which increase the cardiac output, and then noradrenaline, which causes the vasoconstriction, and it also aids in the activation of glycolysis in the liver, and renin, angiotensin, aldosterone axis or system. And similarly, endocrine stress hormones like cortisol, glucagon, thyroxine, these are released. And acute force response include the inflammatory cytokines, TNF, interleukins, cytokines, and they cause further increase of ACTH. They activate the clotting cascade, and they increase the acute phase protein like CRP, fibrinogen, ceruloplasmin, complement C3, and hepatoglobin. And liver down regulates the synthesis of albumin and transferrin protection. And vascular endothelium response by modulating the effects of platelets and leukocytes binding. What is the metabolic response to surgery or trauma? So the metabolic stress response of our body to surgery or trauma divided into ebb and flow phase. The ebb phase is the initial 24 to 48 hours, and flow is from 2 to 48 hours to onwards till recovery. And in ebb phase, we have a reduced basal energy expenditure, and in the first 24 hours, and there is a reduction in the metabolic rate. And in flow phase, there is a dramatic increase in metabolic rate, and this is actually catabolic state, and that will last for many days. And we have a negative nitrogen balance and impaired glucose tolerance. So immediately after abdominal surgery or trauma, most patients are nil by mouth, and therefore starvation and the response to trauma are both responsible for this catabolic state. There is increased heat production in the flow phase along with increased oxygen consumption and weight loss. The overall duration and increase in the metabolic rate in the flow phase depends on the type of stimulus. So in elective surgical operation, there is 10% increase of oxygen consumption and heat production, this response, and 50% increase in the polytrauma, and 20% to 100% in major burns. Once the flow phase has begun, the correction of underlying stimulus, controlling infection or hypovolemia or pain, does not rapidly reverse the metabolic condition of the patient. Finally, if recovery occurs, an anabolic phase occurs where the body replaces its fat and glycogen reserves and synthesis more protein. Clearly, this has a major implication for post-operative nutrition, where calculated daily required nutrition must take into account the extent and the severity of the flow metabolic phase of the patient. How are lipids mobilized after trauma? So again, lipids are the principal source of energy after trauma. So lipolysis start stimulated by the sympathetic nervous system, ACTH, cortisol, and decreased insulin level and glucagon. Ketones are released, and ketones are used by all the tissues except the blood and the brain because they need glucose without insulin. And free fatty acids and glycerol, they are consumed in the liver in gluconeogenesis to produce the glucose. How is carbohydrate metabolism affected by the trauma? So insulin levels decrease and glucagon levels increase. That's why glucagon is a stress hormone in mobilizing glycogen stores and initiating the glycolysis to create a transient hyperglycemia. Increased cortisol level, the glucocorticoid levels also result in insulin resistance of the tissues, thereby potentiating the effect. Glycolysis releases the energy for obligate tissue. Glycolysis releases energy for obligate tissues, which are CNS, leukocytes, and red blood cells, because they only need glucose and without the insulin. This is a very important mechanism because in serious injury or after major injury, leukocytes can account for 70% of the glucose uptake. Body glycogen stores last for about 24 hours, after which blood glucose must be maintained by other methods. So after 24 hours, our body starts gluconeogenesis by the lipid breakdown products, and gluconeogenesis of amino acids mobilized from the protein breakdown. So how is protein metabolism affected by the trauma? So suppressed insulin levels encourage the release of amino acids from the skeletal muscle. A 3 to 4-fold increase in the serum amino acid is usually required for the major trauma. The requirement reaches a peak a week after injury, although it may continue for many days after this. In the absence of constant oxygen supply of protein, the entire nitrogen requirement is gained from the skeletal muscle. The extent of the nitrogen requirement is directly proportional to the extent of the injury, including the trauma and the muscle bulk. Major protein loss results in the endothelial dysfunction and trophy of the intestinal mucosa, and removing the barrier to the translocation of pathogenic bacteria. A loss of over 40% of the body protein is usually fatal. Life cannot be sustained. Why is urine output often low in the first 24 hours after surgery? So here the answer is renin, angiotensin, aldosterone axis are the path system. And after trauma, the activation of renin, angiotensin, aldosterone axis and the increase in ADH secretion lead to the retention of sodium and water, all the expense of the potassium. When we have hypertension, there's arterial pressure in arteriole decrease, and renin is created by the kidney, and renin acts on the angiotensinogen, which is synthesized by the liver. And angiotensin is converted to angiotensin 1, and then it's converted by the enzyme ACE into angiotensin 2, which is this ACE enzyme in the kidney and the lungs only. And then angiotensin 2 activates the sympathetic nervous system, act on the renal tubules, secrete the aldosterone from the renal cortex, and it also called vasoconstrictions. Although the total body sodium may be elevated, dilutional hyponatremia is not uncommon, with excess of serum ADH leading to greater water than the sodium retention. Furthermore, in catabolic cells with a degree of energy failure, sodium pumps are impaired. So sodium tends to drift into cells and thereby further decreases the plasma sodium concentration. This sodium and water retention leads to a low urine output in the first 24 hours after surgery. Although the water retention lasts for only 24 hours, the sodium retention may persist more longer. Postoperative ileus promotes the fluid exposition into the gut lumen, third space fluid loss, and intravascular depletion, leading to hydration and further compounding the oliguria. The most common acid-base imbalance is the metabolic alkalosis, because the aldosterone promotes sodium retention at the expense of potassium, and in the kidneys, as the potassium is excreted, so are hydrogen and in a co-transporter mechanism, leading to alkalosis. In severe trauma, metabolic acidosis can result due to increased production of the lactic acid caused by the poor tissue perfusion and the anaerobic metabolism. How might the systemic response to surgery be minimized? So pre-op, pre-op, per-op, and post-op. So pre-op, minimize the fear and stress to reduce the synthetic activity. High protein load pre-operative nutrition. Enteral feeding if possible before period by mouth required for gastric emptying, and correct control the pre-op infection. Operative factors: good tissue handling, minimal invasive surgery, and short-term duration of anesthesia. Post-op cares: correct hypokalemia, replacement of fluid and electrolytes, transfusion if hemorrhage, colloids for plasma, correction of metabolic alkalosis, control of post-op infection and by antibiotics, enteral feeding and debriding the wound, effective pain control, correction of hypoxia, increase arginine glutamine intake and help improve the nutrient balance, encourage weight gain, wound healing and immune function, and last, trace elements such as zinc to improve the wound healing. Thank you.